Good evening. Before I introduce my guest tonight, I'd like to welcome all of you to our webinar, When and How to Call 911 in a Behavioral Health Emergency. For those of you who are unfamiliar with CMHRC, I'd like to introduce myself. My name is Elizabeth Errico, and I am the Executive Director of the Children's Mental Health Resource Center. We are a nonprofit charity organization that provides guidance and resources for early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype dubbed fear of harm. These disorders are isolating for children and their families and are complicated for providers to treat. So we at CMHRC are here to break down that isolation and provide the support everyone needs to ensure children and adolescents get an accurate diagnosis and a treatment plan that works. To fulfill this mission, we provide a multitude of services for families as well as practitioners and educators, from diagnostic consultation for families and providers to help ensure that accurate diagnosis, school advocacy to provide information on the impact of mental health challenges at school and in the classroom, community advocacy, access to our CMHRC toolkit, which I have to say we're very proud of. It's a web app that tracks symptom intensity and frequency, medication history and compliance, mood tracking. It even keeps track of the local weather for you. All of these are services that are available to both families as well as providers, and we have special membership programs for each that have their own special perks. You can learn more about our programs and services on our website, cmhrc.org. And if you're interested in any of them, you can email us directly through the Contact Us page or make an appointment for a free consultation directly from any of our website's pages that outline our services. As I mentioned before, CMHRC is a nonprofit, and we are able to provide these many services and free programs to families and practitioners only because of the generosity of our community of donors. And I can tell you that from the $10 that was contributed by a grateful 12-year-old and his 9-year-old sister to major gifts from institutions as well as individual donors, each and every gift matters to us and supports our essential work with children, families, mental health providers, and schools. Throughout October and November, we're running a fundraiser, which we call the Giving Thanks campaign. So if you appreciate the programs and services we offer, like this free webinar tonight, we do invite you to join CMHRC to celebrate gratitude and to give hope. And we extend our heartfelt thanks to our generous donors for making our mission a reality. Now tonight, I'm so excited to be speaking with a very special guest. Luke Meehan is a nationally registered paramedic. He is also an American Heart Association trained advanced cardiac life support and pediatric advanced life support provider. He's trained as a pre-hospital trauma life support provider and by the National Association of Emergency Medical Technicians and the American College of Surgeons. Now, I would like to remind our audience that Mr. Meehan is not a medical doctor. He is a nationally registered paramedic. The information in this webinar is not intended to replace the advice of your medical providers. It's provided for educational purposes only and is shared from the experience, knowledge, and expertise of a paramedic. If you or a loved one is in crisis and need to call 911 for help, do so. And as always, follow your doctor's instructions and keep them informed of your condition. Each year, roughly 40% of paramedics' calls will be for a behavioral health emergency, yet these patients are often overlooked and underserved. Luke feels a duty to share his knowledge and experience with the public in order to help alleviate and mediate situations before emergency services become necessary. Education is the key to prevention and top-class patient care. Now, as our conversation unfolds, please feel free to put your questions and comments into the chat and Q&A. I'll be monitoring it and integrating your questions into the conversation as we go. Welcome, Luke.
So, Luke, tell us a little bit about your background and your expertise.
So I've worked as a paramedic and an EMT in the past. Right now, I'm actually not working as a paramedic. I'm a full-time student. Yeah, I've worked both in Texas and New York in 911 systems. I've done rotations in hospitals and different clinical settings, and a lot of 911 calls are behaviorally related calls. So you get a fair amount of experience just working with people who are having the worst day of their life, or just another bad day that happens to be more frequent than we would like. And yeah, so we just have a pretty experienced practice of helping people who are having behavioral crises, and it's definitely part of our training and what we offer.
So, Luke, you hit on something really important there in the fact that when folks call 911 for they're having a heart attack or they fell off a ladder and broke their leg, it's very clear what they're calling for. They're calling because they're having a medical crisis that requires skilled intervention. A lot of times when folks are calling 911 because of a kind of behavioral or what's perceived as a behavioral crisis, I suspect a lot of time folks aren't always sure what it is they're calling for, that they may be calling just because there's something that they can't handle and they don't know what to do next. Can you sort of, is that an accurate assessment, or am I off base?
I think a lot of people don't know what an ambulance or paramedics or EMTs can really offer in terms of mental health or behavioral crises. I think people understand that cops will arrive and help aid safety, and that's definitely their role. But for paramedics and EMTs, we do have mental health training. We do not provide diagnostic care, and it is not our role to provide that. That's really for either your, licensed mental health provider, whether that's a doctor, a psychologist, or a social worker. That's really their area of expertise. But we do have training in de-escalation, identifying different things that could be mental health related in kind of a very provisional way in the out of hospital setting, so we can attempt to help people in that transitionary period between being in a public setting or a home and arriving at the hospital.
So, from a practical standpoint, what happens when someone calls 911? I think most of us think, police or ambulance. When we call, what is it that we should say to be able to communicate effectively that we have a loved one who's experiencing a psychiatric crisis, and that what we really want is medical help as opposed to police intervention?
So in most areas, that help will look like involving the police. Most 911 dispatch centers, the EMS, fire, and police will work together. That doesn't mean that they have to be the lead on the case. You can say, this is a behavioral health emergency. My family member has a history. This is something, and you will get an ambulance. That will look different in different places. Sometimes that ambulance might come by themselves and there might be no law enforcement involved. But in most jurisdictions, that usually includes law enforcement being there for the paramedics, the EMT safety, as well as your safety. But there's definitely a way to articulate that this is, you're not calling for, a crime prevention. You're really calling because this is a health emergency. And most places that I've experienced understand that. The response will be a little different in different places, but you definitely can articulate that you want to go to the hospital. And that's very good to articulate to 911. Typically, when you call 911, There's a dispatcher. Sometimes that dispatch is run through fire. Sometimes that dispatch is run to police. Sometimes it's independent agency. So all of those, you just articulate, look, I'm looking for an ambulance. Usually that will kind of gear in that this is predominantly a health crisis. And depending on what you say, whether it seems like there is a safety concern, that will kind of cue in what degree law enforcement is involved.
I know that our community has a lot of questions about this, so I want to invite our audience to put your questions or comments into the Q&A or into the chat, and I'm going to be monitoring that as we go so that I can incorporate your questions into our conversation. So you can do that without having to raise your hand. You can just go open up the Q&A or the chat and type your question out, and I'll see it there. So, Luke, what are our options when the paramedics arrive, when an ambulance shows up? I know a lot of people think that when that occurs, we're automatically required to go to the hospital of the paramedics choosing. Can you give us some context as to what happens after the paramedics arrive and what your focus is?
So if it depends on what the degree of destabilizing the situation is. So if someone's violent, usually law enforcement will take the lead initially, because as a paramedic, I can't restrain someone without law enforcement being involved. So that they are they have a different authority than I have. I have a medical training and a medical background, so I can offer medical interventions, which can include, different medications and such. But due to legality, it's really the law enforcement officer that will offer kind of that initial safety. But if it's just me, my mindset is that I'm just going to try to make an assessment of what's going on for this patient, listen to them, hear what is going on for them. I always walk into the patient with a blank slate. We get dispatch information, which can definitely key me into, how serious is this? But often the dispatch information is wrong. And you really want to take the patient and their family members at where they're at and what they look like. You can tell a lot by how well someone's doing, just by their presentation. And the first step is, let's get an assessment. Let's see what's going on, and let's try to calm things down if at all possible, and kind of go from there, and then move to the next step. It's, in most situations, if the patient isn't either violent or suicidal, or so like clearly incapable of making medical decisions for themselves in such a way, like an example would be someone who's like a medical example, someone has a stroke and can't articulate why they're making these decisions, then we might say, you know what, we want to call the doctor and decide if they want you to go and make sure you're fine. And there's like kind of a medical an answer to that. We would typically call a medical director. But in most cases, it's really up to you how this call progresses. Like, what do you want? Do you want to go to the ER? Do you just want to call? Like, you're in the driver's seat as a patient or as a family member. It's a minor.
So we have a question here of are there some magic key words that can be relayed to the dispatcher to make it clear that it's a psychiatric need that's prompting the call? I mean, is saying this is a psychiatric need, we need an ambulance first, is that sufficient, or is there something else that folks need to know to say when they call?
So most dispatchers, it's an algorithmic based dispatch. So it's not really there's no magic words. By saying, I need an ambulance, I would like my family member or myself to go to the hospital, and it's a psychiatric based emergency, that will cue you into the call in our process, and we'll get you an ambulance. But there's not really a magic word to, decide whether it's appropriate for law enforcement to be involved. A lot of lower level, depending on really the system of the 911 system, might not send a police. They just might send an ambulance, and you might just go to the hospital. But if anything is kind of unsafe, then most often they will send a police as well as EMS.
And do folks ever send crisis counselors? Are they ever in the ambulances or in the police, traveling with the police?
In some jurisdictions, they do. I think there's a big debate in this in the field whether it's helpful. I think that in my experience, if you're still able to meet with a counselor, there are some resources where you can speak to someone online, on the phone, depending on your doctor has emergency abilities or not. If you're kind of still in that place, maybe 911 isn't the best place to get that. 911 is much more suited to, okay, I need to go to the hospital, and the safest way for me to do that is in an ambulance, or the situation is so unstable that I can't regularly access those types of resources. So some places will include, psychologists or social workers. In my experience, that's not always that helpful because it's not really a diagnostic setting. We do have crisis training to de-escalate situations. And here in New York, we actually have an ability to do have a doctor, a psychiatrist meet with you via telehealth in non-life-threatening emergencies. And like some of those things are really great resources for people who don't have the financial means to reach out to these services. But now there are a lot of online kind of crisis numbers to call, as well as online emergency therapy. I know a lot of hospitals and urgent cares can connect you with these types of resources. So if you're really still in that, like, okay, I need to talk to someone, something's going wrong, but it's not yet like the situation where like I need to go to the hospital, like those resources are good to use, but you should never like not feel comfortable call 911. 911's always available and will, like, our primary function is to help you get to the hospital safely and provide that medical care that is emergency medical care in an out of hospital setting. I don't know if that answers your question.
Yeah, and you mentioned de-escalation, and we've got a bunch of questions here that sort of to pull them all together are basically like, what strategies do you as a paramedic use to help de-escalate patients who are having psychiatric emergencies when you arrive?
So I think it depends on the different patient. You try to tailor your response to the patient. But I think number one for most patients, when you approach the patient with additional resources, that can be very de-escalating. So you have family members who you've seen you in good times and bad times. Having medical professionals show up can be very de-escalating for some people. Sometimes it can be escalating. Some people have had really bad experiences with either EMS, law enforcement, and it can actually escalate the situation. I think the first number one thing is letting the patient know that they're heard, that someone's there to take care of them. Someone's having an anxiety attack, breathing exercises can be really helpful. Just listening, being a good listener really helps. Trying to process what's going on. But we're also not we're not a psychologists and we're not social workers. So this isn't necessarily a crisis management. We're also there to assess whether potentially there's a medical reason for why you're having a crisis, because there are a number of medical causes for what could be perceived as purely behavioral. And it's our job to make sure that one of those isn't causing what's going on, at least in a preliminary way, and evaluate whether a physician could maybe help you more. So, for example, hypoglycemia is a big one. So if someone's diabetic and they are low on hypoglycemia, it can look very, very similar to someone who is exceedingly drunk or exceedingly angry or violent or all these things. Another example is infection can do the same thing. Stroke can make someone very anxious, very upset, very violent. Drugs and alcohol also can alter someone's behavior. So our job is yes, to work with someone to provide comfort and understand where they're coming from, but it's also to make sure that there isn't a medical reason for why someone is not at their baseline.
Yeah, and Luke, you and I have talked about this before, the idea that when you arrive on the scene, having family members who are calm and capable of communicating and giving background information is extremely helpful. Most of our audience, or many of the people in our audience, are parents. And so they may be escalated themselves when they call 911 because they're having their own distress response to what's happening with their child. Do you have any advice to parents as to how they should or could manage themselves that would make the process smoother and easier with you or with other emergency responders?
So I think in general, it's, when people aren't just isolated in typical behavioral emergencies, when someone's sick, people are still upset, but they're not, they're not also like have a broken leg or something like that. But in a psychological based emergency, we often see that there are a number of people who are quite upset. And it's very upsetting to see your loved one in agony or in just having a really rough day. So it's kind of focused on trying to be as calm as possible, because that's going to help your family member the most. Is the calmer you can be and the more kind of just rational and straightforward. But it's not always possible. So it is our job to be able to work with families who are very upset. That's just part of what we do and what we're trained for. But it doesn't make it necessarily always easier for us to do our job. So that the more we can just focus on the patient and helping them, it definitely will make it easier for them to get the care they need.
We have some questions here about PRNs. Are there particular medications that you give to patients who are in psychiatric crisis when you arrive?
Yes. So for us, when we're going to use chemical sedation is what our terminology is, which typically either is a benzodiazepine like lorazepam, midazolam. We can use ketamine. We can use Haldol in some situations. All of these are kind of geared towards the patient who is in an extreme crisis, usually violent, and needs to be sedated and can't be sedated in a way that is alternative. So drugs are always our last choice option. And it's not like when your doctor says, here, like, let me give you this because this is a little bit unmanageable. This is really us saying, I can't manage this patient safely without using sedation. And paramedics can sedate, EMTs cannot. So you're not always guaranteed in a psych case to get a paramedic. And in that case, it would really just be law enforcement providing the restraints, which is actually the worst situation. I hate having those calls. No one wants to be there. No one likes restraining someone. It's really a worst case scenario, and it's designed for if everyone's not safe. And it's always better for people to be safe than not be safe. But that's kind of that's the worst case scenario for us. And I really work very hard to try to avoid giving people sedation. There I think often really good ways to reach someone who's having a rough time that doesn't need to be sedated. But it's definitely something we have in our scope of practice, our resources that we can use. And it's just not an ideal situation because you're taking someone's freedom away from them. And it's really only used for worst case scenarios that you just can't otherwise help someone recenter themselves, calm down, relax. And if we do give medication, then we have to take the person to the ER. That is our policy.
That was a
Because I
question that I saw. If you're given medication, do you have a choice at that point as to whether or not you go to the hospital?
No. So once we give medication, you have to go, and that will most likely include law enforcement at that point. And it will most likely include our medical director having an involuntary admission, at least to the ER. It doesn't necessarily mean the person's going to, not get discharged from the ER. But once I give a medication, I can't allow the person to go home. So now a physician can say, okay, I can basically say the person's refusing to go. And if the person isn't under involuntary by law enforcement, you might be able to get the physician to say, I don't want to go. But from my scope of practice, once I give someone a medication, I cannot let them just leave. And
Right.
it's really a safety issue because the medication could cause respiratory depression. It can cause altered states of consciousness, and it would be medical malpractice for me not to deliver them to someone who, as a physician, can give them definitive treatment.
Now, those medications that you mentioned, are those given to children as well? What's the sort of go-to emergency medication PRN response for children in your experience?
I think most places start with midazolam. And if we're going to give midazolam, it's often via injection. And it's not an ideal situation. It's definitely possible to use. If we can do it another way, it's always better. But midazolam, which is a benzodiazepine, it sedates, makes you sleepy, and is like the starting point. Ketamine's another option, but most protocols don't usually start with ketamine for children. The benzodiazepines are typically where they start, but that's also regional dependent. And it's just, it's something we try to avoid if at all possible.
So you've talked a lot about sort of worst case scenarios. In a best case scenario, you get there, you're able to facilitate de-escalation, the patient calms down. There haven't been any medications that have been administered. The family's comfortable. Is it possible for them to say thank you very much and have you leave? Are they required to go to the hospital? Do they have to then pay for the fact that the team came out to check on them? How does that work?
So usually, in most situations, if you're not suicidal or homicidal, we can't force you to go. It's, you always have the option to refuse treatment. If you're the parent, you have that option for your child. A child can't refuse treatment on their own. We would have to get a parent involved. But you can always refuse treatment. In most places, that won't involve any payment if you don't get transported. I don't actually know of any place that you have to pay if you don't get transported. There are a few places that will fine for unwarranted calls, but that's also pretty rare. So if you don't get transported, usually you don't have to pay, but I can't guarantee that for everywhere. But anywhere I've ever worked, it's always been if you don't get transported, you don't pay.
So there are a number of questions here that sort of center around the idea of how do you determine if someone needs to go or not? Is that a collective conversation you're having with the family, or is that something you're deciding on your own? Is it based purely on the medical side of it? Is it based on medical and behavioral? How do you make that decision?
So most places you work, we have a protocol that kind of identifies what is something where someone would involuntarily have to go. That is determined by a medical doctor who's your medical director. Some of that is determined in what we call offline medical control. So if someone's suicidal, we're going to get law enforcement involved and the person's going to go. against their will. If they have to, we try to not do it against their will. We try to just encourage people, this is a type of situation that you really need to be seen by a doctor. You don't want to force people, but if they're going to be unsafe, then we have to take them. Homicidal, kind of same situation. If someone's violent, also kind of same situation. But other than that, it's really up to the family. Well, we will always encourage people to go once they call 911, because pretty much once you call 911, you've determined that you're incapable of handling the situation without 911. So we're going to assume that means that you need to be seen by a physician to determine how to handle the situation. So that's kind of the net assumption, is that you've called 911. So, we'll ask you, like, do you want to go? But we're actually legally required to say you should go, because we can't definitively rule things out. It's not within our scope of practice to decide if someone has suicidal ideation really needs to be admitted to the hospital, or if they just need to see an increased therapy or change of medications. That's just not our job. Our job is to really get the person to a physician who can make that call.
And I'm assuming that as a paramedic or an EMT, that medical staff on site has communication with the hospital, so that when a patient arrives via ambulance, that information, you've been able to gather relevant information to communicate to the hospital. Does that smooth the way for things like inpatient admissions and the like?
It doesn't smooth the way for inpatient admissions, and it might get you seen initially faster by a physician, but it actually doesn't have any effect once you get to the ER. You're still going to be in the same line that everyone else is going to be in. You'll get faster triage. So if you really need to be seen by a physician, it's definitely going to get you there faster, because we have lights and sirens, and we always give a radio report to the hospital so they know what to expect. But it's not like something that's going to necessarily speed your way through the ER, and we have no influence on inpatient admissions. That's really the ER's policy and how they operate. And it very different from ER to ER. Most hospitals, that has to be two physicians that decide if they're going to involuntarily commit someone. Again, I don't know any doctors who want to do that. It's kind of a last ditch situation. So
I'm seeing a lot of questions here from folks about children or adults who are nonverbal. They may have something going on in addition to the psychiatric issues that they're presenting. They may have severe autism. They may have developmental delays. They may have disabilities of some kind that make it so that they cannot verbalize their own condition. How do you de-escalate on when you arrive on the scene? How do you de-escalate someone who isn't verbal, and what advice do you give to parents and caregivers on how to manage that kind of situation with an emergency responder?
So we get some training on nonverbal patients. I wouldn't say we're necessarily experts at it. Our approach is still really catered to what we're specialized in, which is emergency medicine. So we definitely will. A lot of it is good body posture, speaking to someone respectfully, communicating what you're going to do, especially with a nonverbal patient. Always like letting them know what you're going to do ahead of time, and giving them time to process it if at all possible. And listening to family members about what's going on. We're not psychologists, and I even know a lot of psychologists don't have a lot of practice with nonverbal people, and it's a population that often gets misunderstood and poorly treated. We can be an advocate for law enforcement, so I can say to a law enforcement person, like, hey, you can't approach this person the same way that you would expect someone who's not nonverbal to respond. Try to cue them into operating a little bit more specialized for this particular case, but this is not we are kind of the emergency route, which really keys into that what we do is handle emergencies. We're not a specialized resource that is great. We do try to cater to special populations as well as we can, but we see a lot of different types of emergencies, and it's definitely not the area that we specialize in. So we try to be as responsive and let the parent tell us what's going to be helpful. Like a good paramedic or EMT is a really good listener and tries to say, okay, well, what's helpful? Being a calming presence, not overreacting, just kind of processing and just taking the cue from the parent.
It sounds as though what you're saying is that part of the assessment of the patient is getting information from the parent or caregiver or loved one who's there, and that while some people may perceive that that's not respected, what you're saying is that for a paramedic or an EMT, that's an extremely important part of the whole process of being there, is to listen to what the family members have to tell you about what is previously expected behaviors, what is causing the crisis, what is a deviation from the sort of norm for the individual, and that taking that into consideration is important to the medical team.
So yeah, basically we have two different assessments that we make. We have a primary assessment, which is assessing life threats. So we do an airway assessment, a circulation assessment, and a breathing assessment. That's our primary initial assessment. And that's me determining, is anything killing you right now that I need to fix immediately? And that can be assisting someone breathing. That can be intubation. That can be, I need to get IVs in this person. This person needs fluids. All these types, I need to start CPR. I need to start advanced cardiovascular life support. I need to get an EKG on you. I need to get all these advanced resources that we do have the ability as paramedics to do. We can do EKGs, we can give cardiac meds, we can give all these things just like the ER. We can run ACLS calls, which is exactly the way the ER would run it, with electrical pacemaking. We can do defibrillation, we can give cardiac meds. All that is like within our scope of practice. So that's like our first assessment is, okay, does this person meet the kind of criteria of like they're dying right now and we need to make immediate interventions to stop them from decompensating and get them to the hospital as quickly as possible. So that's like my first assessment. That's, as a paramedic, I walk into every room. We can make that assessment in less than 15 seconds, usually, really, really quickly. Like, okay, is this person decompensating or not? And then we go through a primary assessment. It takes me less than 45 seconds, usually, really, really quick. Then what we have is what's called a secondary assessment. And that involves getting medications, past medical history, hearing what's going on, what's different. And with a psychiatric patient, we're going to do a psychiatrically tailored secondary assessment. And based on that, I can say, okay, well, are any of these things, could they be caused by medical causes? So I think I saw in the chat, someone's like, well, what's an assessment? If someone has any type of chest pain or any type of breathing difficulties, I'm going to get a 12 lead on them, which is an electrocardiogram, which can measure the heart and tell me if the heart's working effectively. I'm going to listen to breath sounds. I can, we have a fair amount of 2 years of training to diagnose things in a non-definitive way. So I can say like, okay, this is mostly like gallstones, or this is a hypoglycemia patient, and really kind of tailor our interventions to that. And then we always make psych the last option, because there's not really that much we can do for a psych patient besides sedate or transport. So, and psych doesn't usually kill you very quickly, or really cause extreme mortality or morbidity. In the moment, it's something that's very debilitating and can cause a lot of life problems, but it's not something that is really properly an emergency, except for like suicidality, aggressiveness, or homicidality. Like the rest is really the specialty of a psychiatrist, whether that's in the ER, your outpatient doctor, or a psychologist, or a social worker. So for us, like, we're determining, does this person meet what we would consider as like a psychiatric emergency? which means like, do they need to be transported to the hospital right now? Or do they need to be sedated? Or do they need to just like kind of more calmly go to the hospital because they have reached a point where they need to be reevaluated by a physician in an emergency setting? And that's like what we do. It's a very different service than a crisis counselor. What like they're going to do is kind of delve more deeply into like what is not working, what are some resources, what are options to try to remedy the situation. What we do is we transport psych patients. That's what our function is. And we can sedate as a paramedic, but EMTs can't. So you might just get an EMT and that's just going to be transport. So from a behavioral or psychiatric emergency case, what our function really is to transport in a safe way. And that may include sedation, but it's other than that, that's really what we offer. So if you're calling 911, what you're getting is people that will help safely transport you to the hospital.
So I've heard you talk in the past about the importance of developing relationships with the people who are on your first aid team and first aid squad, and that families often don't realize that they can go and introduce themselves and talk to the police officers who are going to be the ones responding for their district. They can go talk to the first aid squad and the team that's going to be coming in the ambulance, to get to know them. If they know, look, my child, my loved one has a diagnosis that isn't going to go away, we know what their crises look like, and establish relationships so that when you call, if you call, when you call, those folks who are coming out to your house may have a better sense of what they're walking into.
I think that varies on how large your 911 system is. Here in New York, that's not really possible. If you're in a very small town, which is much smaller, you might be able to get to know the squad. I know we have like patients who call 911 very frequently, and we do develop like a rapport with a patient. We kind of know what's going on for them, makes it easier to treat them. But I'm not going to change my assessment on them because I don't want to, miss something. Someone who has a history of anxiety could also have a heart attack, and I don't want to miss that by not doing a full assessment. So that is our assessment doesn't change. It might help with rapport, but that's like really what we'd focus on.
Mm-hmm, mm-hmm. So there's more questions coming in, sort of talking about, the difference, what you're talking about, the difference between 911 being a sort of opportunity to get services as opposed to calling 911 because there's a true crisis that you're afraid the person or you might not survive. Is that the real kind of distinction there that you're making?
I think the distinction I'm making is that you never don't not want to call 911 if you feel like you're out of control. So if the situation is 911 is always an option for someone where the situation has become untenable. And I never want to not encourage someone to call 911, but you have to know that like from a medical standpoint, the response to that is, okay, let's take you to the hospital. We don't have necessarily the resources to really offer crisis management or in a not orientated way to taking you to the hospital. So if you call an ambulance, what our solution is going to be ultimately is to help you get to the hospital. And
if I may,
I know that, sorry,
go ahead. No, finish.
I think that often people have negative experiences with law enforcement, and that is a challenge. I have worked with a lot of great law enforcement. I've also had law enforcement not be great. If someone's under arrest or with law enforcement, it's still my job to treat them as a patient like any other patient. Now that doesn't always mean law enforcement wants us there. Sometimes they want us there at a level we can't provide. So I've definitely been asked like by law enforcement to sedate a patient. I'm like, this person doesn't meet my criteria to be sedated. Or I've also been sometimes law enforcement is not as keen to call for a medical because they feel like this isn't a medical situation. So I sympathize with people who have had bad experiences with law enforcement. But I also feel that most places I've worked with, if you have medical concerns, will have an ambulance there, but it doesn't mean that law enforcement is not also involved. So we can't necessarily, it's not my place to tell a cop how to do his job. I can try to encourage a cop and say, well, this is actually really a behavioral issue, but I can't tell him not to put someone under arrest. That's just not my role. Where he can't tell me that a patient doesn't need to go to the hospital. So it's like I have to kind of respect that relationship that we have, which is sometimes tense. I've definitely had, like you have a guy who's been in a DUI, and I'm like, well, this guy really needs to go to the hospital. I know he's also under a law enforcement issue, but I need to advocate for him to go to the hospital because he's not okay. I've had that with psych cases too, where like this person is in a kind of law enforcement situation, but I'm like, this person really needs to be seen by a doctor. So it can sometimes be a tense relationship between us and law enforcement, but usually we work really well with law enforcement. And I've also been in psych cases where my safety's been at risk, and we do rely on law enforcement to protect us so we can care for the patient. I can't care for a patient if I'm physically injured. And that's like something we have to realize the limitation of us as medical providers.
Yeah, and I think correct me if I'm wrong, but when you call 911, I think one of the first questions they ask is, fire, police, or medical. And so being
It
able
depends
to,
on the service. Like it really does. Medical, usually, if it's purely medical, they won't send police. But most jurisdictions, psych includes law enforcement.
right. So, but if you were to say, I need an ambulance, I have a loved one who has a psychiatric diagnosis and is having a psychiatric crisis, and I need an ambulance. One would presume that an ambulance would come, but also law enforcement may be required by the jurisdiction to be involved in that circumstance. But do the police have the authority to tell the EMT to, quote, cancel the medical emergency response? Do the police have the authority to say this isn't a medical situation and send you away?
So often the police gets there first. They're faster than we are. They're often more police than there are EMS. If they get there first and they determine whether rightly or wrongly, they can cancel us. It doesn't mean that they necessarily do the right thing. But most 911 systems, the police can cancel EMS. If I'm there, they can't cancel me. I have to evaluate the patient. But if they determine that it's not a medical situation, then they can do that.
So is there a way for the patient to or the patient's family member to say, we want to wait for intervention, we want to wait for the ambulance to arrive? Does the family have the right sort of to say to law enforcement, can you wait in your car until the ambulance arrives? Is that something people have the right to say?
Most protocols will not allow us to approach a scene until it's secured, for our safety. That doesn't mean like 100% secure, but it typically means law enforcement makes first contact. And that's something I know families don't always want. But in a violent situation, especially if our response to a violent situation is to sedate, and it means taking a needle, which it provides like a certain risk for me and provides a certain risk for everyone involved, including law enforcement and the patient and the patient's family. And that really requires law enforcement to be there first. Now, like, this is really the worst case scenario because usually psych patients are not that, like, it's very rare for us to have it be that untenable that law enforcement feels like it's not safe for us to be there. But there are certain situations, like if someone has a gun, I'm not going into a house with a gun until law enforcement determines that's clear. You know, if it's a bomb threat, I'm not going to go into a bomb threat, and it's not okay for me to do that. It's like against my protocols. I'm putting myself at risk, and then I could end up getting hurt or injured or die, and not even be able to help the person. So there are certain like kind of situations that would be primarily a law enforcement situation. So if and that person's medical interests are subjugated to safety, and that is unfortunate for the person. But I can't help them until there's enough of a kind of, like, someone doesn't have a gun, for example, or someone doesn't have a knife that's actively being wielded.
Right. So I'm sort of thinking in the case of what might be more typical for our community, which isn't an adult with a gun. In our community, we're really looking at children. And so, for there, it might be a child who's pushing, shoving, kicking, biting, throwing things that they're capable of lifting. And so in those kinds of circumstances, do parents have the ability to, you said that a child can't give consent or refuse treatment. Parents have to do that. So are there special sort of protocols that have to be followed for a parent to say, I want my child taken to a behavioral health ER as opposed to a generalized ER? Is there some protocol that a parent has to go through to get that kind of specialized treatment on behalf of their child?
So that's one of the advantages of 911 is that I know, and like, well, hospitals have psych residents and stuff like that. So in our computer, we can say, okay, what's the nearest hospital that has psych doctors? And usually the care that psych patients get with psych doctors is far superior to that of a regular ER. I can also see what's a pediatric psych department. That doesn't mean you're going to go to a psych hospital. Very rarely can I take someone directly to a psych hospital. There are a couple of situations where that's not true, but usually you have to go to the ER first. But which is unfortunate for a lot of people. Is usually it's primarily a diagnostic evaluation that happens, and not a lot of treatment goes on besides sedation, which is kind of similar to what we do. But they do have a lot more advanced diagnostic capabilities than we do because they're physicians, and they do have psychiatrists who can, determine that this person needs different medication management, much more advanced, which is a much higher degree of practice than we have. But I can cater someone to a place that is going to have psych residents versus just going to your local ER, which may or may not have a psychiatrist on staff, and you might just be dealing with a regular ER doctor who may not have any pediatric experience. And in my personal experience, I can't guarantee this is always the case, but the less experienced the provider, the more likely they use sedation.
Interesting.
Just because they don't have the kind of experience to manage it more conservatively.
So there are a lot of questions here about suicidal ideation, verbalization of suicidal plans, and a question about the difference between 911 and 988. can you explain the difference between those and when you would use one versus the other?
It's not our scope of practice if you're to tell you which one to use. That's really a physician question. I can tell you the difference between them.
That'd be great.
988 is a suicide hotline, and you will have people who are explicitly trained in that. In certain EMS jurisdictions, they'll have a protocol that will specify whether all ideation calls have to go to the hospital, or just like active plans. I know in Texas, where I worked for a little bit, we would always encourage someone who's suicidal be evaluated by a physician, but we wouldn't force someone to go unless they had an active plan. But in New York, it's just any ideation gets you sent to the hospital involuntarily. So it's really state and often locality based. What is an involuntary, hospital ride to the
And
ER?
is that same for teens and children? If their parents say, my child verbalized a plan before you got here, is that sufficient for the parent to be able to say, I want them evaluated, I want them taken to that hospital that has a psychiatric facility?
I can't tell you what everyone's going to do. If it was me and I heard that, I would take the person to the hospital. And then it's kind of up to the ER doctor whether they're going to admit or not admit. And that's usually 2 physicians required for an involuntary admission. And that involves often getting a psychiatrist there, but sometimes not, depending on the facility. So for me, if someone's like, okay, I'm concerned this person's suicidal, I'm going to take them. It's kind of more the place where we're going to have a question is, okay, so patient says they're not suicidal. Parent says the patient says they're suicidal. Then they say they don't want to go. That's where I'm going to call my medical director and be like, you need to talk to the family member. You need to make this determination because I have to tell them they should go in that situation. So
now 988 is a suicide hotline. Do they send people if you call 988 and say, my child is having a psychiatric emergency and is verbalizing suicidal plans? Will they send someone, or is that exclusive to 911?
I don't know. I don't have,
Okay.
I'm not a 998 operator. I don't know what their protocols are.
Okay.
You'd have to ask them or ask your therapist or your
Sure.
professional. So I
Okay.
know like some suicide hotlines do track calls and will send welfare checks. I don't know what their policy is.
So we have a lot of questions here sort of talking about how would you improve the system? You've worked a lot of places, a lot of different parts of the country, a lot of different jurisdictions. You've worked with police all over the country. Overall, not specific to one place, what do you think would make this emergency system better? And is there anything that citizens who aren't a part of that system can do to facilitate that improvement?
I think this is a better question for your physician or your therapist. For us, I think that the best thing is to try to get better care outside of the hospital because we really our only option is to transport you. We don't offer treatment for behavioral emergencies that is definitive. We can offer, treat. So I do think that in a lot of cases you have better cooperation between law enforcement and EMS that can be improved. I know that New York has this new treat in place option, which allows you to speak to a physician per level provider. I think that's a great resource for someone who's having a behavioral emergency that maybe doesn't necessitate going to the ER. But also, I know that there are a lot of online options for that too, with trained medical professionals, whether that's psychological. But yeah, it's not a great place to be in to need 911, but sometimes it's necessary, and we are there always to provide that service. And we'd always rather someone call 911 than not to call 911, because if you don't call 911 and the person ends up either committing suicide or having a severe medical health consequence, that's never what we want. But I also sympathize with parents because there's just not a lot we can do for that patient. And I know that a lot of patients have frustrating outcomes in the hospital. They end up getting there, and the hospital really can't do much more for them. Often it takes a long time to get a good medicine regimen, and mental health care is really expensive in the country, often not always easily accessible. So all these things are kind of not a paramedic. And I don't think the improvements necessarily to come from our field, is I guess what I'm trying to say. That what we do is what I hope to be will get limited in what we need to be involved, because once we get involved, there's not much I can do to help someone's day. There are a lot of patients that I can really help as a paramedic. And
So
psych patients usually aren't that, which is sad.
right. So it sounds as though what you're really saying is know what your 911 response team is going to be good at, which is not ongoing crisis support. It's not treatment of any kind. It's not diagnosing. It's providing emergency stability for transport to the hospital. And one thing I've heard you talk about in the past that I know we're out of time, and I just want to end on this, is the idea that I've heard you speak on before, is that when it comes to psychiatric issues, that it's really important to know ahead of time, in the time when it's calm and there is no crisis, what exactly your threshold is for calling 911, and knowing what it is that you want out of that interaction, and not being reactive in the moment to your emotional distress, but instead being able to say, I've made a plan. I know what requires a call to 911, and we're not necessarily there yet. So can
Yeah,
you
I think
speak a little
that's
bit
the
to that?
best, to really try to work with your doctor or your therapist to determine, okay, what is a 911 call, to have a really objective criteria. I know it helps us treat patients to have an objective criteria that's like, okay, you're either in the criteria where you get sedation, you need to have sedation, or you're not. And I think that can really help families to not be like questioning whether I want to call 911, or maybe I want to go to the hospital, maybe I don't. It always makes it worse for the patient if they end up having to go. Um, so I think trying to figure out, well, what is a situation where my doctor or my therapist or my family members decide, like, okay, what is an untenable situation? What is an emergency situation? And we're not really that's not our scope of practice to determine. Our scope of practice is just to respond and to offer the resources we have to provide. And we can provide some treatment. We can really, what you're getting the most of is for us to rule out, like, really easy to rule out medical causes, provide safe transport, maybe sedate if you get a paramedic. But that's the area that we do. And I don't, we can also be kind, compassionate people, but I also know that not every paramedic is always kind and compassionate, and I wish everyone were. But paramedics are, sometimes not great. So I don't want to, say that every paramedic is always going to be super nice, or every paramedic is always going to be super compassionate, because sometimes they're not, and it's sad. It's part of what is our professional obligation, what we need to do as providers to be good providers, but that it's not always the reality that people experience. And for that, I'm sorry that that's their situation. But it's what a paramedic or an EMT does in a psych call is provide emergency medical transport and rule out some initial um, medical concerns, and then really allow a physician to definitively rule out other because an initial evaluation, we're like, okay, this person's not hypoglycemic, or this person doesn't have positive strokes on it, doesn't mean they're not having a stroke. So we can't definitively rule these things out, or this person is not having an endocrine emergency. We can just kind of do an initial evaluation that says, okay, we can't detect these things, but only a physician can really rule these things out and say, okay, I'm going to clear you to go home. And that's not our scope. It doesn't mean we can't offer a lot of really awesome treatment for a lot of different medical cases, like specifically cardiology. We can keep someone alive who would otherwise die if they didn't have us. But that's, at the end of the day, psych calls are hard for everyone involved, patient, family member, provider, because no one wants to see someone having a rough day. And it's often something that people have for a long time. And, it can be frustrating. I can express that I've definitely had psych calls where I'm like, wow, this has been really tried my patience. This has been difficult. And I'm sure parents have had that too. But that's not my job to express that to a patient, or it's my job to just be a professional and be available to be their lifeline. And that's what a good paramedic should do. Unfortunately, not always the case. But yeah, that's what our scope is.
Well, I want to be respectful of everyone's time. I appreciate all the folks who took time out of their evening to be here with us to listen to this. I know there were a lot of questions that did not get answered. We're going to go through those, and we're going to come up with additional resources to help folks get the information that they're looking for. So thank you so much for being here with us tonight. Next month, our webinar is going to be on seasonal changes and how changes on the clocks and the temperature and the weather and in the seasons can impact mood disorders, bipolar disorder, and its newly identified phenotype dubbed fear of harm. We will also be having a two-part clinical seminar in November and in December. The first part is on Wednesday, November 29th, and it's on the fight, flight, freeze response, the limbic system, and how it interacts with symptoms of mood disorders, and how we can use that information to help us manage, treat, and de-escalate. So that will be part 1, November 29th, and part 2, December 20th. We hope to see everyone there. If you would like a certificate of completion, please email programs or learning@cmhrc.org, and we will get you that documentation. Just please specify if you are a provider or a family member. We have different documentation for each. Luke, thank you so much for being here. As ever, it was so informative, and it was also tremendously helpful to get all of this information and to get your perspective, and we very much appreciate your time. So thank you so much for being here.
You're welcome.
We look forward to seeing you all again. Have a wonderful evening. Any additional questions, please email learning@cmhrc.org, and we'll do our best to get your question answered. Thanks so much, everyone. Have a great rest of your night. Bye.